Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. All right, welcome to KIMEcast. Tony Mikla, Russ Dunning. We've got a great guest today, Dr. Sean Robinson. Sean's been a good friend of ours and just a great orthopedic surgeon here in the Sacramento region. It's been great to have you, man.
It's nice. It's nice to be here. I mean, I grew up in Sacramento, so coming back was kind of key for me.
Oh, awesome. Yeah. You had a great experience. Now you did your residency and your fellowship down with Kerlan-Jobe down in LA, which is a big spot.
It's a big spot. It's big shoes to fill with people like Elatrosh and, Olympus Vosti and Mike Banfi, a lot of really big names down at Kerlan-Jobe. And I think the nicest part about it is it's really kind of picked up steam in the last 5 to 6 years also. They had a little bit of a lull, and, obviously historically it's incredible. But,
oh, yeah. I think every time, just to go to a place like that moves the needle, just obviously infamously over the last few years, you got Rogers there and, now Otani's there,
Yep.
These guys going through the process and working with Dr. Elatrosh, and then for you to be underneath that wing and learn from those guys. I know I would have loved to have been there.
Yeah, I mean, it's pretty incredible to see how, especially Dr. Elatrosh thinks. I think his mind works a little bit differently. I mean, most people who are intelligent and successful tend to work in a little bit more unique manner.
Yeah.
So being around him was definitely interesting. But they all had their own little kind of aspect to give back to sports medicine also, which was great. Like Olympus Vosti is another great name, great guy down there. Works a lot with the Angels.
Yeah.
Same thing. Does a lot of elbow, but he has his own little thing he can give back in terms of our education for fellowship.
Expand on that. Like, what makes him superhuman in that way?
Yeah. So what's cool about Orr in particular is he was different. Like, you had someone like Mike Banfi who just was busy as heck, very, very talented, skillful, technically. You have Elatrosh, who is Elatrosh. I mean, not too much needs to be explained there, obviously. And then you have Orr, who's kind of took things a little bit differently, is a little bit slower, dialed back practice. He spent a lot of time with each patient, which is always very interesting because traditionally these days we don't have time to spend, which is unfortunate. But Orr would really dive into like the complexities of like a UCL injury or the complexities of tensioning a UCL and getting them back to the field, obviously eventually. But the most important, what Orr kind of taught me is he always asked me, how are you going to make your practice successful? And I always thought, oh, well, I'm gonna be really good technically. And I'm gonna learn how to operate. And he's like, no, that's not it. He was like, it's your relationships.
Yeah.
Which was always very, he gave me that kind of insight in terms of how do you build a relationship? Who's important to you, going forward? And one of the main things he told me about was therapists, right? And he's like, who's your physical therapist up there? And I was like, well, I don't know. I don't know who's gonna be taking care of the patients after. And he's like, no, that's where you got to start. You got to figure out a team to work with. So he kind of gave us that. It kind of gave more a practical side of starting a business.
Oh, that's good advice for sure. I think having relationships and building like that network. I know, like you bring a lot of that stuff to the table here in Sacramento, which is amazing. Like it's amazing to have you as a partner. And when we have a patient, it's like, hey, there's a very short list of guys to see, and you being top of that list is like, hey, I got a shoulder thing, I've got a knee thing, I've got an elbow thing for sure. It's like who should see these people and consult with. I just think what you bring to the table when you work closely with these folks, like you clearly like care about your patient, care about the outcome, you put time into them. And then the technical work is amazing as well, right? Super sound. I think we can always see a difference, right, with a surgeon. Where this is where a therapist, usually knows like who can operate and who can, what's going on. But somebody asked me this the other day, like about like rehab times. And I'm like, man, like, it kind of goes back and forth. It's funny because you talk to a surgeon and they're maybe a little bit humble sometimes. Yeah. You're humble, but sometimes they're not so humble. But usually they're kind of humble. They're like, yeah, it really depends on the therapy and depends on the patient and all this stuff. And I would say the opposite. I'd say it really depends on the surgeon because these guys now, you're coming out of surgery and like the level of pain people are in is so minimal.
Right.
Whereas like 10, 20 years ago, it was a different story. Like the collateral damage was much greater. People were like in a lot of pain. Sleeping was much more difficult, especially on shoulders. It still is difficult on shoulders.
For sure.
But sometimes you get some people coming out where like they're almost pain-free, like on week one. It's like, this is amazing. And I think it comes down to like clean technique, clean approach, no collateral damage, get in, evaluate the situation, get out,
Yeah, no, I agree. I mean, I think that, the traditional thought is, orthos cavemen, right?
Yeah.
And so we kind of go in there and we bang around and we just beat stuff up, right? But I totally agree. I think it's way more intricate than that, especially these days. I mean, even when I was in residency, 10 years ago now, one of my attendings there, he harped on soft tissue management, right? So every time you touch a piece of soft tissue, whether you're using a forceps and you're picking something up, whatever you do, it needs to be ginger and gentle. Every layer of cell is important. And so I apply that, right? So everything I do personally from start to finish, and obviously pain's so subjective and it's so relative to, right? Some people have a ton of pain no matter what.
Yeah.
But I do agree that there is really a lot of positive in taking that time and that care for the surrounding soft tissues.
Yeah, it's amazing. I mean, we see it so clearly. Like even if they have a little bit of pain, but just the freedom of motion is there, right? Versus if it's a little more traumatic of an experience, I feel like we see it.
Yeah.
No, it could be that maybe it was necessary. Maybe the cuff was destroyed and you had to bring a lot of stuff back and you had to put multiple anchors in and create a little more of a mattress there, a little more of a process there. And then of course it's going to be a little stiffer, but it's just amazing. I think the work that you do specifically, when we see stuff post-operatively, it's just super clean, super smooth.
Yeah, no, I appreciate it. I think we take a lot of time focusing on that. Because even talking on things like tourniquets, right? So tourniquets, everyone used to use them all the time, the entire time. People would have them on for 2 hours. And my first direction away from tourniquets, which I think lead to a lot of post-operative pain.
Yeah.
It could be, the reoxygenation kind of pain. It could just be the compression pain. There's all kinds of things it can cause. But, I stopped doing tourniquets, especially for like total knees. For meniscus repairs, I still use them on ACLs. But, minimizing that time or not using them at all, I for sure see a huge difference in terms of their pain.
You'll kind of cycle them on the tourniquet and off the tourniquet throughout the surgery, or?
So I won't even do that. I just won't even use it. So like for a total knee, and this is another reason why I think my total knees hopefully have less pain. They generally do, is when I incise and I don't have a tourniquet up, I'm going to see every bleeder, right? Sure. Unfortunately, what a lot of pain is after is effusion.
Yeah.
Right. So if I go in and I'm able to get everything cauterized, and that goes with everything, ACLs, anything that's open, right? They're going to have less bleeding, less tension on the capsule, and they're going to progress quicker.
I think it's a massive. That's my whole conversation with patients that are in pain post-operatively. Is like, if the swelling is the biggest pain generator, right?
Sure.
And they feel the pressure of the inside the capsule pushing out against tissues, and I think that's probably their biggest pain generator.
Yeah. No, I agree. I mean, that's why compression, ice, and anti-inflammatories, I'm like, those are your friends, for sure. Moving it's your friend. They think that's counterintuitive, right? Until you kind of educate. Yeah. But getting the motion through it, loosening up the tissues, and that also help push out these effusions, right? So
absolutely.
Those basics. I mean, we're not even talking about narcotics, which we try to limit those as much as possible, and I think we do a better job now.
Yeah, sure.
But
I think it's incredible when not being a surgeon, just thinking about like a total knee, as you mentioned, that you guys go off there and literally like cut off the bone, and then the two bones, cut off the femur, cut off the tibia, put these new implants in, pound it in. It's not exactly the most gracious process, it's a little bit impactful. And then, but people can come out of that like almost pain-free, which is just crazy. Like that's actually possible.
It's wild. Yeah, you'll have some people, and what I see is it's based a lot on how they came in. Like there's a gentleman did, 6 months ago, and he's worked with you guys, and he had a flexion contracture of like 45 to 40 degrees. It was something immense, right? And his knee was just absolutely terrible. We fixed him. He actually stood up within 30 minutes after surgery. I come out to check on him. Leg's totally straight. He has no pain. He's like, oh, I've never seen my leg do this before. He gets all the way straight, bends it all the way back, and he took off from there. It's incredible.
Yeah. I do think the more they suffer prior to the surgery, I feel like then whatever pain they have post-operatively is much more tolerable. I think that's a thing.
Yeah.
If you go in with like, I'm pretty good, I'm just going to have the surgery as like a preventative thing, or like I was kind of early in the process, I don't want to get any worse, then I feel like that trauma is still a decent shock to the system.
I agree.
Yeah.
I wholeheartedly
Which I'm sure
agree.
is why most orthos are like, just push it off until it gets too far. But I think it's a big deal. Like, I hate when people go so far that they lose parts of their life, right? They lose their ability to function or be independent.
Right.
Start losing these things, and like, I still can't get my knee done yet. I can still walk. It's like, yeah, but you hate your life. Like you can't move,
Can't live.
and then you're compromising other things. You're compromising your health and your fitness and your activity level and things that you enjoy.
Right.
Because we're holding on to this knee that we could easily, like the technology is such nowadays, you go back in there and you get these people like 10 years back and easily.
Oh yeah.
I see that as a quite variable opinion from orthos of when is it okay to pull the trigger and get an elective, total joint replacement, whether it's shoulder, hip, or knee. And at what age, at what state of health, and how much stability do you have? I'm hearing some conflict. And is there internal conflict in the orthopedic world of like where this lives from a general health standpoint, lifespan standpoint?
For sure. I think there's a lot. So again, the traditional thought of total joint replacement is wait till you're 70, wait till you're, that way you have one done and hopefully it lasts 10, 15 years. But that's such an old school way of thought. And I think more and more of us younger guys think differently. And I'm not to say the other people haven't adapted, but but it's about quality of life. So when I indicate someone, I don't think about age anymore, even though that's kind of semi how I was taught. What I think about is quality of life. So I may have a 47-year-old guy who has terrible knee or terrible hip arthritis. And for me, I give him 3 checkpoints. I'm like, these are 3 checkpoints I like you to hit before I do a joint replacement. Poor sleep, trouble with everyday activity, and avoidance of enjoyable activity. Because those 3 are quality of life.
Mm-hmm.
Like, right? If you want to put in a very boiled down, right, that's quality of life. And I'm like, we can do injections, we can buy you time, but if you're at that point where you're already miserable, what are we waiting on? As long as you understand the risks.
Mm-hmm. And what are those? Go.
Yeah, so in terms of doing it younger, there's always a risk of bleeding, which we talked about before, which is very low. Infection, that's obviously the big one. Total hip dislocation, that's another big one. And then just wearing out of the implants or loosening over time. So I traditionally say for hips, it's like 25 years, knees 20 years, but every hip is going to be different. There's people walking around with 40-year-old hips, and they're doing fine, right? Mm-hmm. And our technology is even better now.
Sure.
So my thought process is, hey, you're 47 years old, you're miserable. Your quality of life is awful. Mm-hmm. It's either let's wait till you're 70 and you're going to miss this prime middle part of your life, or let's do it so you can enjoy your life.
Mm-hmm. And then what happens? What happens after 25, 30, 35 years? The joint's too loose or it's sloppy. What is that?
Yeah, so where the bone, so like if we're thinking about a total hip, it's all press fit. So it's all this etched on titanium gets put into the bone and the bone grows onto it, right? And so what can happen over time is that bond can loosen up. It could be due to the plastic wearing, the plastic wears, the body tries to attack the plastic and also gets some of the bone too. And then you loosen, that gets loose. And so then you have to replace those parts, which is always higher risk of infection, dislocation, complication every time you do a revision. But that's how they loosen. And so if you think, of a total knee, where traditionally we're all cementation. Well, I don't cement hardly any anymore because the press fit technology is so good. For the same purpose of the total hip, I want the bone to grow on. I want a biologic fixation rather than a cement fixation, because cement is, that's eventually, in theory, going to loosen. Yeah,
it's probably harder to do a second replacement in the future too with cement.
Yeah, so it's
not necessarily
tough to know. So the reason why cement's tough because you have to get all the cement out, which can be awful, right? The issue if you have to revise a press fit one that's grown in, well, as you're getting it out, you can pull the bone out, right? You can pull out
bone,
right, or fracture and if you lose bone, the biggest thing about revision is trying to maintain as much native bone as possible when you're taking out the old stuff. And so if you take out a lot, you may be left with not much to work with.
Yeah.
Mm-hmm. So.
Wow. But that's always been the patient. That's what always the patient says, right? Is like, oh man, I'm too young, which has always been the thing.
Yep.
But I think that's a great perspective to have. That's the same thing I tell them. Like, man, if your life starts to get compromised where you can't move to some degree, then I think the other risks of death are higher. Like cardiovascular disease, diabetes, obesity, these other factors where it's like, because that's what we hear all the time. It's like, well, I can't run anymore, or I can't walk anymore, or I can't go on trips or whatever. And then start putting weight on, they weigh 20, 30, 40 pounds. So you said a stat one time that the average person gains 5 pounds a year. Is that
a pound a year.
A pound a year after the age of 40 or something like that?
It was earlier than that.
I
Really? Figure out that
That's
age.
an active person. That's an average person.
Well, the math comes out to 1 potato chip a day. It's really disgusting. 1 potato chip a day gives you a pound a year, 10 pounds in a decade, 30, 40 pounds after the age of 30. So you're 30, 40 pounds overweight by the time you've been able to get a knee replacement by some surgeons.
Interesting.
Yeah.
Huh. You don't want to run into that
The rest is data. It's not,
But then
Data
to your
man.
point, though, then you try and lose that weight, but you're chronically in pain. So then your cortisol is through the roof.
Right.
Your sleep sucks. So you're like trying so hard, but nothing moves the needle. Then you're taking the GLP-1s and the whole thing just like cascading downhill.
Yes, exactly.
So you're trying to really, cut the head off the snake and hoping that they have really healthy 30 years to handle a revision.
Right. Exactly.
That's a great play. I'd play that.
Yeah.
Yeah.
I mean, you can
If
enjoy your
I was
life.
dealt it,
Yeah, right. Exactly. I mean, then you have people who have hip arthritis or knee arthritis, then every other joints go out of whack, right? Then you hear lumbar spine stuff all the time with people with total hips or with hip arthritis, pre-total hip. I just had a guy the other day who was like 3 months out and he had terrible sciatica before doing our total hip. Did our total hip. And he walks in, gives me a hug because he's like, not only my hip is great, but my back doesn't hurt anymore. And I don't have any radiating pain. So it can benefit the health in so many ways.
So many ways. Yeah. I think it's amazing what you guys do. Getting the alignment set up and the leg length. I mean, there's just so many variables you have to take care of. It's a true art form.
Yeah, it is. I mean, I'd say with total hips, which I do a little differently than a lot of people who do total hips. I go anterior, which you guys know, which there are less of us in Sacramento right now. There's only me and I think one other person who's doing anteriors right now.
Yeah.
But a little different about mine is I do what's called a bikini incision. And so it honestly goes right at the bottom of the panty line, basically. And it's transverse. The beauty of it is that's where Langer lines are, right? So Langer lines flow in this direction, and so they heal way better. The reason I moved to that is the longitudinal is traditionally a longitudinal incision. But even if you're thin, you're still going to fold up here. There's like a 10 to 15% delayed healing of the wound. And I saw it a few times. So after that, I was like, all right, well, we can go for a cosmetic, by doing a bikini and, cosmetic, it's going to heal better. I have less concerns about wound. So we started doing that and we just haven't looked back. It's been awesome.
Awesome.
It's been awesome. People love it.
Yeah. See, these are things that people don't realize when you choose your surgeon as a patient, these are all, that's not going to come out. Well, I guess you would tell them that in the meeting, but people don't know the difference,
Right.
But it's amazing the little subtle choices that these guys make that I think make a big difference on the outcome, and it's like when you say things like that, like I do it a little differently than others. That's it. I think that's the specialty of surgery where there is a decent amount of freedom between here's the main strategy that we're going to do an ACL or we're going to do a rotator cuff repair. And people don't realize that when they get in there, the amount of decision making that you have to do in that process to make sure whatever it is, to make sure you can get the right fixation, make sure you get the right graft size, to make sure you get the right angles, to make sure you get the right tissue, and not too tight, not too loose. There's so many subtle things that really make a difference in the outcome. So I'll give you guys all the credit in the world. It used to be like, therapists make surgeons look good. I'm not so sure. I think it's just both are helpful. But
I'll paint the opposite situation that we have a lot of patients that face. So I have a friend right now who immediately became a patient after he tore his Achilles. He's in an HMO system. And so the surgeon that he met with briefly once prior to an x-ray, the surgeon reviewed the x-ray outside of the appointment, then text or emailed the patient, hey, I have a ability to do surgery this Friday if you want. At the appointment, the surgeon told the patient, we can either be conservative with this or you could do surgery. The outcomes are the same. I don't care what you do. And then a day later, after reviewing the x-ray, said, yes, it's a full rupture. We need to do surgery. I have surgery this Friday. When you give all of this,
super clear.
Yeah. Right. Like what? And then my friend's like, what do I do? I'm like, I have no idea. And he's like, the surgeon wants to do surgery this Friday. I haven't even talked with him about the details of the surgery, but he says I have availability if I want. I'm like, what? So I think what you do from an education standpoint to be human about it,
right,
and say, hey, these are the options. This is my approach. This is why I do things. You create that relationship, I think, that you learn from your mentor. If your relationships live with trainers and coaches and PTs, but they're also with the patient. Versus an HMO system where unfortunately the line's out the door of who's next in surgery. They could care less of how much time they spend with you. It was really amazing to see the lack of care by this particular surgeon within the HMO system. Not to blame all HMOs, the system, but he asked for my insight. I'm like, find an ortho that actually cares, something about your ability to return to sport, because I have no idea in this space.
Right. And that's a good point. I mean, the Achilles talk is really important, right? Because all the studies show you don't have to have surgery. Conservative care works fantastic, unless you're a high level athlete. Like that, that's a different category. I'm talking about 98% of people out there.
Yeah.
You don't need surgery. And so how I treat that situation is obviously I take time for one to show them X-rays, show them MRIs, more importantly, obviously, right? And then give them their risk benefits and alternatives to both.
Yeah.
Right? And so it's crystal clear.
Yes.
And then generally, if they're on the fence, then they'll ask me, "What would you do?" And for me personally, in Achilles, I wouldn't get mine fixed, right? I'd be like, put me in a boot, put me on a heel wedge. I'll go that route. And I always tell them that. Some people still say, "I'll just do surgery. I want it to heal quicker and move on a little bit." Quicker,
I love it
that
I love it that you put yourself out there and make an opinion. I'm frankly amazed at how many people don't have an opinion. They're just like, "Oh, here's the facts. Pick left or right. Good luck to you." Like, how do you live with yourself? So I
There's
think
no way a person could make that decision that's not educated,
Yeah,
Correct.
Yeah. So I love it that you speak with integrity on that front. I applaud you, because I don't think there's enough medical people that are willing to put some stake in it. Like,
Right.
these are the facts. I think it leans left. I think it leans right for these reasons. Rather than, here it is, good luck. I have no idea. I don't really care. Like, what?
Yeah.
How are you getting paid that much money to not care?
Right.
Like, it's
Yeah,
you're like
so
a
true.
robot, So thank you for being human.
Yeah, well, I think I think that's how I've built, everything that I do. Right, I like the connection with the patient. I want to make sure they understand it as well as I can help them to understand it. Right, I think that it's building any type of rapport with any relationship you have. Right, just because they're a patient and they're them and you're you doesn't mean you guys can't be on the same page.
Yeah.
So it's a critical aspect for my practice.
Love it. So let's talk about that. So your practice. So I remember when you first got back up here to Sacramento and building it up, and now it's been thriving.
Yeah.
Right.
Doing great,
Having
yeah.
a good time with it. And we talked a lot about total joints, but that's not really like your thing. Like,
Correct.
I mean, you're obviously, as a sports medicine guy, soft tissue stuff is your passion, whether it be shoulder, knee, and everything between, of course, the UCL and the elbow as well.
Right.
So what's going on with the practice? How are things going? What's it look like?
Yeah, so practice is great. We've gotten very busy over the last few years, especially, and again, I attribute it to a lot of relationships that I have with people. You guys are top of that list, and I'm thankful for the relationship. But yeah, no, it's going great. We're very busy. We're moving to Folsom, which we're really excited
That's awesome,
about.
yeah.
So we got a new building, and it starts construction in April.
Oh, sweet.
Should be moving in August. And so I think probably 60% of people we treat is from the 50 corridor, right? El Dorado, Folsom, Placerville. Yeah. And so it made sense for us to come up this way. Awesome. So we're excited about that. It's going to be a nice little, new perk. We'll have our own space.
Heck yeah. Yeah, it gives you so much freedom to set it up properly where you can, I think that's a big thing, right? Set it up so the patient can flow more effectively through it.
Right.
Time's efficient, all that good stuff.
Yeah.
Because you're in a modified space now, right? That you had to kind of move into.
Right. Yeah. So I mean, fortunately, my first 5 years have been a little chaotic in the start. Yeah. I think they are for a lot of people coming out.
Yeah, absolutely. It's part of the process.
It's part of the process, right? I jumped into one practice, didn't work out, which is fine. I learned a lot, right? I learned a lot about business, to be honest, and how I wanted to, run my business.
Yeah.
I was able to jump in with, Steve Broad, great friend of mine. Yeah. He's retired. He retired a couple of years ago, but he let me come in to his office and gave me a place to land. And from there, we've just kind of taken off. So I've been very fortunate for my situation. Yeah. But now it's time to take the next step.
I think that's good though. Those steps, like when you're starting your practice, to have a bit of chaos or see a couple different things, and it's really important to identify that you came from such a great place, such a great fellowship and residency experiences where you're like, hey, I know what I want. And then you kind of land and then you see ooh, but now this isn't working. It's not what I want. And it's kind of a long ways away from me, what you hoped for. And then being able to say, all right, now I know what goes really well, and now I know what doesn't work, and then you can do something.
Grow from there.
Yeah. For me, that was massive. I mean, I pride myself, and I love it when a PT goes to a good really good internship experiences, I think really is really important because it's one of the few opportunities to really see what the best in the world look like, similar to what you did with Kerlan-Jobe. Mine was at Exos and Athletes Performance, and I think that Mike Reinhold does at Champions fantastic, and there's 4 or 5 elite centers similar to how there is in orthopedics. And I think when someone goes there and they get to see what it is to be at this elite level, and then they go back to like a job in more of a routine, if you will, that's not as sharp as a saw as you might see it at an elite practice. It's really easy to see it, and then you see the gap in between, and then I think it really can motivate you to be like, we can fill this.
For sure.
That's my passion, is that I think that there's no reason why a general population person can't be treated like a pro athlete. You just have to know what buttons to push so you can get over the insurance hurdle.
Right.
And be like, all right, I need to get this done, that done, this done. And it's crazy. I had this kid the other day. His dad's an orthopedic surgeon as well. He's a spine guy. But the kid's like 16, sprained his ankle, not a massive injury, but we know that because all the tests that happened. So it was awesome. So the kid's sitting there and his dad's like taking me through the history, like, all right, so he did it on Sunday, and then we got an x-ray on Monday, got an MRI on Tuesday, we got 2 ortho consults on Wednesday and Thursday with the foot and ankle guys, the 2 best guys in town. He's like, so here we are. It's like, what was it? Like Thursday he saw me,
Yeah.
I looked at his son, I'm like, all right, you need to say thank you to your dad. This is not normal to be able to get all that done in 4 days. I said, I could have helped you with that, but your dad did it for you. I said, you should say thank you. I said, because otherwise this takes people 3 months to get that process done. And there's no reason for it outside of just bullshit bureaucracy. But I think, I know that your passion for the same thing is to like, let's get people the help they need and let's do it, in a timely manner. Right. And give them some priority.
Yeah, I mean, you have someone like that who's a young individual. They don't have to be young, but they have an ankle sprain, right? Yeah. It's obviously non-surgical.
Yeah.
And what's critical is early, functional rehabilitation.
Yeah.
It's what they need. And so trying to, if you go through that around the typical rigmarole, well, they're 3 months out and now they have a stiff ankle and still swollen. Yes. They're weak around it. They're not dynamically stabilizing.
Yeah. Can we weight bear right away? Can we clear this and can I get weight on right away? I don't care if it hurts. If I know it's not broken, then I got to go, right? Yeah. But if it's broken, then okay, then I shouldn't do that.
Right.
And the X-ray is good, but the MRI would be better.
Sure.
To help us clarify that and make a better decision.
Yeah.
Which turned out to be good. So he's in a good situation. He's got a little bruise in the talar dome, so we can weight bear through it. But at the same time, we have to be a little cautious with that long term, and that might cause some swelling. It's really good to know that. I wouldn't have known that in a typical general population ankle sprain.
Right.
I would have guessed it. After, 2-3 weeks, it's still swelling when we're walking on it,
Yeah.
I know the X-ray says we're not broken, but...
Yeah. You don't see everything with the X-ray, obviously.
No. We got another great ankle patient who didn't see everything with the X-ray either and turned out great, despite all the reasons that we probably shouldn't have pushed it as fast as we did, but it was awesome. So it's all good.
That's good.
We made it back. Well, good. So you guys moving to Folsom. Where are you going to operate from? So you operated West Coast, right?
Yeah, West Coast is that's my main spot for sure. And for one, it's a beautiful place.
Yeah,
right.
Awesome,
it's new.
Brand new. Yeah,
they do a great job.
Yeah,
every patient loves. I have people who are down maybe Lodi, Stockton, Oak Grove, and they they complain a little bit about coming up there, and then as soon as they do, they're like, all right, I'll be back here. Right? Yeah. They love it. So West Coast is for sure like the number one place for me. Sutter, Alhambra is great as well. We take a lot of Sutter patients. They're also another well-known surgery center on the Sutter side. But those two, eat up probably 90% of my time. Right, and I still have a hospital if I have a sicker person who needs to get a total joint, or just not sicker but less healthy. Sure, is a better way of putting it.
Yeah. Are you doing the total joints outpatient now?
Yeah, pretty much everything.
Yeah.
I mean, we'll do. Like a typical West Coast day will be 6 or 7 cases typically. Yeah. 2 rooms, usually 3 total joints, maybe 4, and then the rest are sports. I mean, they function so well that I'm done by 3. Yeah. Patients generally are out 3-4 hours on average after they're done. Yeah. So if I finish the first one at 8 a.m., they're going to be gone by lunch, which is great. Yeah. Great for them. Great for everybody. Yeah. Right?
And that's a great thing too. Like a patient may not realize that, but that really comes down to like the team that around you. Like the anesthesiologist plays a huge role in that, I'm sure. And then of course the nursing staff and the support team that make that coming out of the surgery possible, right? That you can get everything you need done in a limited amount of time, right? Limited tourniquet time, and then and then get them out.
Then get them. Yeah, it's great. They function extremely well over there. So that's
It's a big deal.
Top choice. It's a really big deal, and I think patients notice it, right? Because most patients have obviously had surgery of some sort before, right? But when they come back from West Coast, they have such a good experience. I don't think I've ever heard someone say they had a bad experience.
Yeah, it's awesome. It has huge value.
Yeah.
Okay, let's go back to that Achilles thing. I got a question about that. So I think this has been that is a common thing. This idea of should we go operative or should we go non-operative? My reading on that in the past, I've managed a couple non-operative and then several hundred operatively,
Sure.
And I see all the data. But my reading on that was, yes, it can be the outcomes are equivalent essentially, as you said, from the data standpoint. But one of the key areas there was you really have to get on it early, I believe. Like talking to some of the guys who wrote the paper and like really got it going. My understanding was like if they get it either booted or casted, like almost immediately, like within 48 hours or something pretty rapid.
Right.
Whereas if it's like goes on a little while and 2, 3, 4, 5 days and they haven't been able to kind of stabilize it, there were some thoughts that maybe it wasn't as good long term. Have you seen anything else on that? Was a couple years ago that I was kind of looking at that more.
Yeah, there's a couple aspects to that. So one, I'll give you like a story to start off with.
Yeah.
I had an Achilles who, same situation, gave him the operative, non-operative talk, and they wanted surgery.
Yeah.
We got to surgery about 3 weeks after the injury, which you usually want to get there within 1 to 2, ideally,
extended,
right?
yeah.
And the nice thing about the Achilles, and this is the same thing with a lot of the larger tendons, they have the peritoneum, right? Peritoneum gives vasculature, gives health, and et cetera to the tendon.
Yeah.
And so that's the same thing with the Achilles. Like when you operate on an Achilles, you open up the skin and then you open up the peritoneum. Once you open up the peritoneum, that's where all the hematoma is, and that's where the healing occurs. So if you don't open that peritoneum, it has basically a pipeline to rejoin each other,
right.
which is why it works so well.
It's not like it's just floating.
It's not just flayed open, right? Yeah, they have a direct track, and then the hematoma, all that's great biology. Like it's gonna bounce off that to heal.
Yeah.
So this one case went in there, it's about 3 weeks out, and I open it up, open the peritoneum, and what do I see? I started doing a Thompson's. They're starting to kick a little bit. They're already starting to heal to a degree.
Yeah.
Which is shocking,
Yeah.
right? And so I'll just make that point. Say it happens very rapidly.
Yeah.
The healing process. And I had him in a boot, but I didn't like immobilize him with a cast or a splinter or anything. But it was just, it shocked me. So I got in there. I was like, well, I know these do well non-operatively,
But to see it.
but then you see it,
Yeah.
and you're like, that thing is shocking.
Now, from what I saw, I did a quick read on this with my buddy being hurt, and it seems like that there's going to be a differential of how much of a gap it has to go through. So my buddy's gap is 6 milliliters, and we found with a little bit of research, with the help of all of our AI friends, that around 10 is like, that might be a long bridge. And how I interpret it with my PT sense is like, well, if it's too long of a bridge, you might have this very poor insufficiency of the muscle to operate with a really long Achilles tendon. But if they can form a bridge maybe with only 5-6 mils, that's not so long. Maybe it's just a little more flexible than your side, but you could train that.
Sure.
Is that kind of how you think of like going back to like high level sports? You need enough tension so that you don't bottom out every time you step backwards. Your heel is always slamming against the ground.
Right.
Then if it's like a 20 mil gap, it's like a really long tendon. That's insufficient for power.
Sure.
But if it's a short gap, now this is a great ability to heal conservatively. Is that how you think too?
For sure, and that's a great point, and that's why it's so critical with the high performance athletes, right? Like they need their appropriate tension on their Achilles, and how a lot of people do it operatively is you'll have both legs out, sitting out, and you can actually check the tension of the normal side to the tension of the operative side. But going back to your point, having the appropriate tension is how they're going to generate their force, right? If they have all of a sudden you increase their length a certain amount, well, they're not going to be able to fire that muscle appropriately, and they're not going to be able to utilize it, jump, step back. It's all going to be inefficient. That's a great point. That's why the high performance people really they should have it. I mean, all the studies say if you're high performance, you should have it repaired. Yeah,
because you want it tight, appropriately tight.
Appropriately tight. You don't want to overdo it. I mean, you can overdo that too. Sure. But I mean, anyone, any professional or high level collegiate athlete out there, they're getting theirs fixed. As far as I know.
It was interesting in this case.
I haven't seen anyone not in a competitive environment.
Right.
Well, it was interesting in this case to like see that the differential, one might choose how much of a gap does it have that the bridge has to go through. And you can only get that reading based off of MRI.
Right.
And the doctor flat out said, I don't need an MRI. You have this pathology. Do you want to go left or right? where it seems like I was reading that the differential of going left or right, having surgery or not having surgery, might be dependent on how much of a bridge it has to form. So it was amazing how I was helping my patient literally have a fight with the orthopedist, even though the orthopedist saw him for 5 minutes without any imaging when he saw him. I'm like, wow, talk about a lack of information. I thought you guys loved data.
Yeah,
and I was dealing with someone who like didn't need any data.
Yeah.
Like, pfft,
That's shocking.
I know what to do.
It's shocking.
But it's up to you.
You know, that reminds me of another story. If I can take you out of topic here for a second, because
Tell me.
This drove me nuts. So my cousin, he's my best man. He's like one of my best friends. He lives in Boston. You know, I went to med school in Boston, so he and I obviously have had a lot of time together. But nonetheless, he had a shoulder injury. He calls me, you know, about everything basically. But he had a cuff and he had a partial thickness, articular sided, you know, less than 50%. You know, I saw his MRI, wasn't that bad, but he's had ongoing pain. He's been in PT, no injections yet. And so he's like, all right, I'm going to go see this guy. And he showed me division chief of yada yada for sports medicine. And he goes in, has his exam, and I was like, think about PRP, think about some other things to avoid the knife. Sure. Like, if you need the knife, you need the knife, right? But let's not jump into it. And so he calls me after, and he's like, yeah, he says I need surgery. I was like, oh, really? Yeah, well, what about trying an injection? No, he said that's not going to work. I was like, well, did he talk to you about PRP? No, he said that's not going to work either. I was like, well, what was his exam? He's like, what do you mean? I was like, well, did he touch your arm? Did he look at you? And he's like, no, he didn't touch me at all. He just looked at my MRI, talked about it for 20 seconds and told me I need surgery. And I about lost it. Right? Yeah. I mean, this comes down to just, there's a certain way to handle any and every situation. You can't make a surgical decision without touching a patient. You can't do it, especially something like a cuff, right? Partial thickness cuff in a 40-year-old. I'm like, you really got to be, if you have like someone who has an acute ACL and the MRI is torn, like, you know what they got. Like, you don't need to do too much to them at that moment, right? But if you're seeing this partial thickness cuff with full motion, like, how do you know it's his cuff that's causing his pain? Mm-hmm. Maybe that's not his pain. Maybe it's his AC. Maybe it's his bicep. Maybe it's periscapular. Maybe it's not even structural.
Right.
I don't know. So that goes back to that. I was like, it put me on an absolute, like a little rampage.
Don't just treat the image. Then,
don't just treat the image. Yeah. And you're not supposed to, right?
Yeah,
and that's
rule number one.
Rule number one. That's my whole discussion with people. They'll be like, how does my knee look? Oh, it's terrible arthritis. Yeah. And I'm like, but how are you doing? What do you do on a daily basis? Yeah. Oh, well, I walk 10 miles a day and I do this and that. And they're like, do I need a knee? Why would you need a knee?
Yeah.
Yours works great, right? We're not here to treat the image.
That's such an interesting thing too. I think it's people always ask that question, like, man, I'd like to get my whole body scanned so I can see what things I need to get fixed. Be like, no, that's not how it works. do not think that's a good idea, right? Because it's like, I saw somebody the other day was as a shoulder situation, and they were like, their arm was weak, but not too bad for a week out of, like, they felt it pop, and then they got weak, but it's kind of starting to come back already. I'm like, yeah. Like, well, here's the problem. We can go get the ortho. You can get the MRI. It's probably going to show that you got a cuff tear. The problem is we don't know if it happened a week ago or if it happened like 5 years ago. Right. Maybe it got a little bit worse this week and you was always there. We don't know. So really the best practice is get what you can out of it. See what you got. See what kind of hand you've been dealt. In a month or two, if you're in terrible pain and you have to move forward, then let's do it. But if you're not and you're actually doing better and you feel like you're getting stronger and things are progressing, then you take this, you ride the wave until you either plateau and you're like, okay, this is good enough for me, or it's not good enough for me. Right. Or you start to fall back down and you're like, okay, this sucks and I can't do it. Well, then the choice is clear.
Then you know.
Yeah.
Right? And that's the whole point, like an injection too. And it's important not to inject like a cuff too many times.
Sure, yeah.
I usually say during a treatment algorithm, it's twice. You'll get 2 cortisone, then we go to PRP. But cortisone has been shown, if you do more than 2, higher risk of infection and lower chance of healing. Yeah. We know that, right? But if I can get you some good PT, if I can get you an injection, and I see you marching back and you're getting functional, I don't necessarily care that you have a cuff tear. If it was an acute one and you can't lift your arm, that's a different situation. Yeah. But that's a very small percentage of what we see. We see with the attritional tears.
Yes.
You just got to give them opportunity.
Yeah. Which takes time. And that means, I think, in my opinion, the best orthos are the most patient orthos. Yeah. To rush an incision, you're a high level athlete with an acute or Achilles rupture, like to do within the first week, or a fresh ACL. There's only a handful of diagnoses where speed's of essence. Other times it's like, let's see what time can do.
Yeah. What's the rush in the majority of things? Right?
Yeah. Especially on a cuff. Yeah.
Yeah. Especially on a cuff.
Yeah. That's the patient one.
Yeah.
For sure. But yeah, I think like to your point, yeah, the Achilles has to be, well, it's at best Achilles, biceps done quickly if it needs to be done, you know?
Yep, hamstring, proximal hamstring, like any tenderness like that.
Yeah, because then it can retract.
Because it can retract. You can't, and that's going to affect function. Like the beauty of the shoulder is 17 muscles attached to that shoulder girdle.
Yeah.
And I tell people this all the time. I'm like, you have a little tear of one muscle, the supraspinatus.
Yeah.
It's not the end of the world. Let's see how you do. You have a lot of compensatory mechanisms. And obviously age and all kinds of other factors come in to play in terms of deciding. But you take like a distal bicep or you take a proximal hamstring or an Achilles, like you don't have very much compensation there. You're going to lose function and strength if you don't get those fixed.
Yeah, and I think, like on the cuff, I think I don't know what the data is off the top of my head, but I know it's super strong that if you scanned like the whole population at the age of 50, I think you're like over 80% have some version of cuff tear.
Yeah.
I'm just guessing.
Yeah, there's been variable.
I'm sure it's high.
Yeah, it's super high. So there's been variable numbers. I've seen as high as 60% over 60, as high as 70% over 70. And then I've seen others say like 30 to 50 over 60. It doesn't, either way, it's a high number.
Yeah, at least 50-50
Yeah,
basically.
there's a lot of people walking around with cuff tears. Doesn't mean they need surgery.
Yeah, they're not dysfunctional, not even symptomatic.
Yeah, not even symptom. The majority of them are not.
Yeah.
It's pretty crazy.
Yeah, I was thinking back when we had Dr. Brandon Beamer do like a little video series. This was like, I feel like it was like 10 years ago. He was feeling my shoulder. He was like, so when the shoulder's doing this, I'm like the dummy. I'm like, all right, do whatever you want with my shoulder. And he like feels this like click and he's like, fight against me. He feels like click. He looks at me and goes, you got a little tear in there? I'm like, who cares? Who doesn't? You know? He kind of laughed. I'm like, I'm good, bro.
Yeah.
I'll call you when I'm 75 and I can't sleep.
Yeah. Agreed.
It's like, yeah, I'm good. I did my PT.
Yeah.
Yeah.
I got a good pair.
It's all about function. It's all about function. That's really what matters.
100%. All right, so let's talk about ACL a little bit. We were talking about that when we were walking in here a little. So you're BTB guy.
I'm all BTB.
Yeah.
I mean, almost all.
Yeah.
Right. So I mean, but I'm 98% BTB.
Yeah, I do have one cadaver one from you. So we do.
Oh, you got one.
You have one allograft.
Yeah.
But I think that was the justifiable one. Based on age and activity level and all that good stuff.
Yeah.
But yeah, I think this is always the question that comes up with clients. You know, patients ask, hey, you know, almost like what you had. You hear this by some surgeons, not by you, and not by other good ones. But I think you hear it by some where it's, you know, hey, what they said I could get this graft. I had somebody the other day. His kid's in the Bay Area, actually, and he's like, yeah, the doctor said I could either do a quad tendon or do a BTB. And this kid's like 24 or something. He does MMA stuff. He's really active. He likes to run. You know, he's a really active, athletic guy. And he's like, his previous ACL, he's had ACL on his other leg. He did quad tendon. He did BTB. It failed, and then he got a quad tendon. And he's like, it was great. We rehabbed the quad tendon.
Yep.
And then so he's like, it's great, so I think I want to go quad tendon. I'm like, bro, you choosing the graft, in my mind, is like the worst person. It's in the worst hands possible. Like, let the ortho choose the graft.
Yeah.
Like, if the doc you're working with wants to do BTB, and that's the doc you want to go with, that's what you should get.
Right.
Because it's the skill set of using the graft is actually pretty intense. Like,
Sure.
I mean, if you use a hamstring, if you use a quad tendon, if you use a BTB, if you use an allograft, like those all have a completely different skill set in managing the graft harvesting as well as the graft development and then implementation. They all have their own issues. But at the end of the day, I could say that I guess the data says that most are pretty well equal.
Yeah.
But I think it's the hands of the surgeon that you're in, like, is a way bigger factor than graft selection.
Yeah, I mean, I agree. So, I mean, like you said, the data is the same. And I tell everyone this who I talk about ACLs or a patient, right?
Yeah.
I mean, I'm a BTB guy. It's how I was trained. It's what I love. I think bone-to-bone integration is critical. It's a beautiful graft.
Yeah.
I've had to go back and do second looks, and it just looks beautiful. It looks like a native.
Yeah.
You can't convince me otherwise. You know, I don't see the same when I go back on like hamstrings.
Yeah.
Certainly not allografts. Quads, you'll see it look pretty good too.
I think there's nuances there that I'd like to hear about, like the details. And when you say it's a beautiful graft, and maybe it's the angle and the curve and the tension, what is that like? What does the user think? Like, you know, same outcome of like it works, but what about like how it works?
Yeah. So what I like about a BTB, the patellar tendon graft, is it's a very stiff graft, but it's not the strongest graft. So actually, if you do the quadrupled hamstring, that's the strongest graft. It doesn't really matter, to be honest. The stiffness doesn't really matter. That's why if you do a hamstring, you see someone prep it, they put it on this tensioner for a while to take out all the tension, right?
Yeah.
You don't have to do that with BTB, right? It's a very stiff tissue. And so it's a beautiful graft in the sense that when it goes in, it has these beautiful little fat striations to them. It looks good. It looks taut. It looks like an ACL. When you put in a hamstring, you see just this bundle of 4 tendons, and it doesn't
look nice.
It just doesn't look as nice. This is just a personal thing. Something about I love the look of a BTB. It just looks beautiful.
Yeah.
But then on like the second looks, this is where it really gets me. When the first time I did a second look in practice, this kid, he was young, 16, and then he ended up tearing his meniscus. So I had to go back. Like it was like a year later, and I went in and looked at the graft, and it was synovialized. It looks like a native ACL ligament. Mm-hmm. I mean, it looks absolutely incredible. And again, I've gone in on other ones, from that were hamstrings that they don't synovialize the same. They don't look like a native ligament. And so because of that, I think this incorporation is much better. I think maybe the vascularity of the patellar tendon is much better. It's a healthier ligament, so you kind of get that better synovialization. But again, the studies show they do the same. It's just my preference, right? Yep. And I tell everyone this, and I stand by my point. I'm like, look, I'm a BTB person. I tell every patient that. I'm like, if you are interested in a quad, I do quads in a primary setting for people who are on their knees a lot. Like I've done it for jiu-jitsu, jiu-jitsu, stuff like that, right?
Yeah.
Just
it seems to take tension off of the front of the knee, so if you kneel on it, you're less likely to get a tendinitis or less likely to crack the patella if it was an acute situation.
Right. And I don't see much of that anterior knee pain personally in mine.
Neither do I. That's why I wonder why so many people, not so many people, but I know that this is gold standard. I love it myself. I think it's the rehabs kind of go well either way, but I see people kind of like trying to like go away from it. And I just kind of wonder like, why is there a trend that way? Why is everyone still looking for another graft option? I think that it seems like we've ran the course on these variety of grafts. And my conversation with patients, I think the data is pretty strong on this, that it's probably less about graft and more about surgical technique.
Yeah.
Like where you put the tunnels, how tense you put it, a variety of other things.
Right.
Well, and the strength of rehab, because majority of rehabs, 1 year out, we can test the single limb RSI and still find a difference with the majority of post-op patients.
Yeah.
So, flat out, I think therapists tend to underload these patients.
Yeah, for sure.
Even if the surgeon's phenomenal. Maybe they're doing all these different techniques to try and find better outcomes when really the thing is that everyone should be testing a harder test.
Yeah. I mean, I think consistency is key. Right. So, I mean, I don't do hamstring. For one, I wasn't trained in it. I don't really like it. But second, right, I mean, I'm not going to give a patient an option of a quad, a hamstring, a BTB. I'm not going to do it.
Yeah.
Right. I'm like, if you're interested in hamstring, I'll send you to Hunter Green.
Yeah. Go get a hamstring guy.
He's fantastic ACL. He does a fantastic ACL. He's a great surgeon.
Yeah.
His
preference is hamstring.
His preference is hamstring. And that's fine. So if you want to go see a hamstring guy, I'll send you to him.
Right.
But I mean, I don't really waver from my opinion on BTB.
Yeah. What about the width? I used to have younger female athletes, and the doctor would say I would lean more on hamstring for a smaller person. Is that a thing of like how much of that middle third of the patella you can grab?
So, I mean, even on the smallest of people, I mean, I've done some really small people, you can still get a full 10 millimeters across and still have plenty adequate tendon on either side. Where I've seen actually the opposite in discussion with people. When you have a small individual and you try to take their hamstring, it tends to be very small as well, right? And so when you fold it over, it needs to be at least 8 millimeters. There's studies that show if it's less than 8, they have a higher failure rate. Sometimes you have to see those surgeons that have to augment with an allograft now. So you're putting an allograft with your autograft, right? Which isn't the end of the world, but you took away the concept of an autograft in my mind. Yeah. And that's the beauty of the patella. I can get 10 millimeters every single time.
Yeah.
I've never been like, got to switch.
Yeah.
That just doesn't happen.
Right. Yeah.
It's very reliable. Sizing, everything. It's very reliable.
Yeah.
You just got to make sure you don't break the patella.
Yeah.
Yeah. And that's
super rare complication.
But that's the thing.
It can happen.
That's like the one thing that like people will come back to is be like, well, I don't want to risk that. But the odds of that are so slim.
It's so slim.
It happened once to me, to a professional fighter, and the doctor or the patient had a surgery in Las Vegas, and he did lunges too soon.
He just popped it.
Yeah, did lunges probably like around like week 4, week 5.
Yeah, must have a little stress. I mean, maybe went a little bit deep on the harvest and then just gave a little stress, weak point.
Just kept doing it because That's what he does.
That's his profession.
He's a grinder.
Right.
He's like, well, it's supposed to be a little painful. Okay.
Yeah.
Until,
It'll be 9 out of 10. Is this a little bit?
Yeah. I can't lift my leg anymore.
It's about as tough as it gets. Like, oh, okay.
Yeah.
I've only seen it once, but it's an interesting fear when it does happen quite rarely.
Yeah, 100%. So on the ACL front, how do you feel about the return to sport kind of steps and process to it? I think that this is an area that we're working in that's of interest for us, because I just feel like the process is not. It doesn't put you guys in a great spot. More recently and better in the recent years, with more of the data we can provide as far as like RSI and speed of contraction and some of these things. But I feel like so many of the protocols, and they were based on time. Like, hey,
Right.
it's been 3 months, so you can start to jog, and at 4 months you can run, and at 6 months you can return to practice activities. And I know it's fluctuated, based on data that it used to be. We were trying to push you back at 6 months before you were a surgeon.
Right. Yeah.
Back in 2005, we were okay, we can go back at 6 months as an accelerated program, and now we've learned that that's not a good idea anymore.
Yeah.
Maybe 9 at the earliest. Better, the longer you wait, the better.
Right.
But if we actually started we're hoping to be able to use a little more data to make the decision better, because I think for you guys it's tough, because all you really have is time.
Yep.
You're in your
Agreed.
office and you can't really watch them run or jump or change direction.
Right. All I look at is, if we're getting close to a release, first of all, I say, does Tony and Russ say you can go?
That's a good question.
Does your testing look good? Right.
Yeah.
That's always the question if they're at a high quality therapist office.
Yeah.
Otherwise, I'm relying on quad girth and quad atrophy. I'm relying on a single leg squat. I can't see them do a triple jump. I can't have them do that in my office. I don't have that opportunity to see their control.
Yeah.
I can see them do a step up, step down on a stool to try to gauge their mechanics.
Yeah.
But if they're not good,
Yeah.
all I can tell them is how they should position it. I can't work with them.
Yeah.
Right. So I think it's really intriguing to see where it'll go in the next few years if we can alter it. I still think you need the 10 to 12 months.
Yeah.
No matter what.
Yeah. Right.
Right. Because that comes down just purely to maturation of the tissue.
Yeah.
Most autografts take 10 months to mature, to be considered complete synovial eyes, and allografts 12. Right. So I'm still kind of think that that's an important time
frame, yeah.
from that point of view. But in terms of advancing them earlier, getting them onto different modes of recovery.
Or even though it's been 10 months, right? So that's the only piece of data that you really have. And then, like you said, you ask the therapist, and in the traditional environment, it's been like, therapists, they're good.
Yeah.
Like you said, from a quality therapist, hopefully there's a little more criteria than that. But
Right.
I think what we're learning now, which is really cool, and obviously doing a battery of tests, I think, is the biggest thing. Like, we do a battery of things, and of course, girth is a big one. Single leg squat strength is a big one. Knee extension strength now side to side is a big one, and kind of all determined around atrophy and hypertrophy. But we're able to look now at like muscle contraction to be like, all right, can you demonstrate force generation on this side and single leg jump compared to this side? And then that's one variable. And then what do you do? What does it look like in a fatigue state? And then what does your rebound look like? Meaning, like, if you land from a jump and having to bounce again, how's that stretch shortening cycle look? Call it RSI, if you will. And by looking at that number, we can see, all right, your speed of contraction is the same as the other side, or it's a little bit slow. And when we know, like, all right, injury rates are going to be high, even if hypertrophy was there, their still injury rates are relatively high. But if we know the RSI is low, to be like, hey, your speed of contraction on this side's just diminished, which we all can kind of sense in the past.
Sure.
But now that we can measure it,
Yeah.
I think it'll be a nice step to be like, all right, hey, like, cleared or not. And this data is like emerging. It's not like it's like, I mean, we definitely know that it's solid. It's just a question of like, what's good enough.
Yeah.
To like go back
To
to
apply
clearance.
it.
Yeah, exactly. But it's definitely knowing like, okay, there's clearly compromise, and it's got to be a factor, because we know that the injury is going to happen with speed. It doesn't happen walking around. Really.
No, it's a huge factor, right? I mean, the whole first part of the rehabilitative cycle is learning proprioception, right?
Yeah.
And then this is like the advanced proprioception. It's how's proprioception when you're in action, right? Where's that leg? Are you firing the muscle in order to control, right? I mean, that's a critical number. I think it's probably the most important in terms of preventing re-injury, and then also matching it to the other side, because as we know, adolescent females, right? They have a 25 to 50% risk of rupture on the other side, right? After they've had one. Like, they're super high risk. So getting that number dialed in and equal, I think would be, very beneficial.
I'd like to see in the industry that PTs are able to like step up more and work closely with docs like yourself, where they can give you data where you can make a better decision. Because obviously, it does come down to you guys making the decision, which is the right choice. But I also feel for you guys where like you're not working.
We don't have it all.
You're not working with a whole bunch of numbers or data points, and you don't get a chance to see how it's completely unfair. Like person walks in the room, haven't seen him in 3 months. Like how's it going? Feels great. PT says it's good. I'm running. Everything feels good. It's like, all right, well, sounds pretty good. I think give it a shot.
See how it goes.
That's essentially kind of like where they've left you guys. I think we totally left. I think we've done a huge disservice to like not getting you better information. So we're committed to like improving that battery and then giving you information about how the battery works and what to look for.
Yeah.
So that you can make an easier, better decision.
Yeah, I mean, it's so critical. As we've been talking about the majority of the time, is the relationship we have together is critical for the outcome of the patient, right? And that's what I try to, when I have a patient, and whether they've seen you guys or not, or they've seen any PT, I encourage them to see people who I know. Yeah. I'm like, look, here's the beauty of it. If you go see Russ, you go see Tony, they text me. Right? We text each other. If we're worried about something. Your care isn't just happening when I see you every 2 months or when you see them, a couple times a week. Like it's happening kind of around the clock. That's the beauty of being involved in a certain team of individuals.
Absolutely. It's so good for the patient when there's that kind of relationship where it's where we're on that kind of communication level where you can anticipate that that from us that we're going to give you this type of outcome, and then we can anticipate the same from you. And then if we have to talk because maybe something's a little bit variable or something's off, then we can rapidly. It just shows that like you really care about the person's outcome, which is kind of what we put our hat on as well. To say like that we really care about the outcome, and then when you have people like that, like the outcomes just get better. It's unbelievable. Yeah. It's such a great thing for the patient. Well, oftentimes feels lost. And
to get a little bold, do you track your outcomes with particular surgeries like an ACL?
I don't. No, I don't. I mean, I think putting that in motion is the hardest part, and why I don't really do it. I mean, I don't really do Q scores, any of that kind of stuff. It'd be nice. I've always thought about doing it, but I just don't. Setting that up is probably the biggest barrier.
It's difficult.
Yeah, it's challenging.
Oh my gosh,
it's very challenging.
We could probably help with that.
Yeah,
absolutely, we can.
I mean, it's about like surveying them, right? It's the surveying the patient, getting to complete the survey, getting good follow-up data that's like long-term.
It's kind peak, baby.
Yeah, it's true. Yeah.
Yeah, I mean, I think it is important. I mean, because I kind of go off general gross knowledge of the practice and where people are and how they're doing, and they get back. Did I hear from them again? Right, but it's not objective.
Yeah,
right?
I think that's a good question, and I think very few people do this in private practice.
Hard. It's so hard. How would you? I mean, that would be like
to justify Sean's answer. Like nobody does this. So don't say his no is like a negative thing. It's just the reality of healthcare. It's very, very difficult to do. Yeah. I don't know where I was going to go with that, but
I know we can. It's just, but it does come down because we form pretty strong relationships. I'm assuming you manage at any one time maybe about like 500 to 1,000 people at any one time.
Probably, yeah.
Over the course of a year, for sure.
Yeah. Oh, over the course of a year, no doubt. Yeah.
I only manage 70.
Yeah.
So any one PT, I think when PTs do their job well, they really only manage about 70 people a month, and sometimes it's the same 70 people the next month, but whatever. So in other words, we can keep track of 70 people better than you can keep track of 1,000.
Right.
And I think we all could. I think collectively we could be better. So that way we get to say, hey, if your knee extensor strength is here, if you have surgery here, if you get back your jump here, when you do those things, our risk is 5% re-injury rate.
That would be the interesting thing to kind of get to on this type of thing is that's where I was going to go with this idea is like, what are we asking? Because I think in surgery journals, if you look at outcomes and what's considered to be a good outcome for a surgeon, not taking anything away from the field, but usually pain relief is like success.
So always have the VAS score, right? That's like always in there.
I mean, if they have less pain, then the surgery was successful. Right. And so the problem we have as an industry is that doesn't work for an athlete.
No.
The function becomes the question. Yep. And then it's like, okay, so the only question that really matters is, were you able to return to the same or better level than when you left? And this is what Andrews Institute did a great job with this and studying all their baseball stuff, looking at UCLs, looking at slap repairs, those types of things on baseball guys. Is they have actual measurements like, all right, 80% of the guys who went through this procedure actually made it back to the same level or better, which is that's a really powerful piece of data.
Yes.
Which is really hard to get, and the only reason they got it is because they're tracking professional athletes, so they can just call the team or they watch them on TV.
That data is all there.
Yeah, you can see their velo, you can see you can see all the numbers of their professionally, so it's pretty easy to see.
Yep.
The general population is really hard to track down because also even the same idea, well, same or higher level, maybe they were a senior in high school playing soccer and they just soccer career ended.
Right.
Were they going to play in college? Well, they were never eligible. They were never going to play in college. So they stopped because they stopped, not because of the knee. Right. So it just gets really gray.
And then follow-up is hard, right? I mean, general population, the follow-up's challenging. Like generally, when you do these studies and you're at an academic institution, they have like research, they have a whole team they collect this stuff, right? They're looking at it 2 weeks, 6 weeks, 3 months, 6 months, 9 months, 12 months, and then yearly thereafter. It's like, how many people do I see after 12 to 15 months? Not that many. I mean, the majority of them are just like, back with their life, I say, hey, see me every year or two.
Yeah.
Do I see them? Probably not often. Right?
Not very often.
They're gone. And then not having a squad to dedicated to track them and ask them the questions, fill out the survey.
Well,
it's hard.
To me in medicine, the gross amount of documentation is either for legal or for billing. Either of which suck for the user.
Yeah.
What the user wants is what's my personal history that I care about. I was amazed. I had a patient the other day, and she's going to go see this special doctor, and I told her, okay, you need to write this down. You have a post-op hip by 5 years. You have a shoulder issue that's been chronic for 2 years. You have. I basically gave her medical record in story form that she can understand and then retell to the doctor, and that doesn't exist. Yeah. People have like their portal. Oh yeah, good luck. It's like a sea of X-rays and MRIs. And what we all need is like a history that's relevant to us. Like what is our whether it's an athlete history, an athlete scorecard, a person's like own card of hey how they're doing. That way they know I had this kind of graft. It was in that year. I had these issues. This is how we solve it. I think
that's a great point. I found myself doing that too. I did that with the person the other day as a total hip replacements, having a little bit of trouble. And I kind of helped her lay out like, all right, this is how you want to present it so that don't overwhelm the doc in the office. He's got 2 or 3 minutes with you. Like if you unload with him on your emotional side, he's just going to shut down and walk out of the room. Like, let's be honest
blink.
Yeah. Oh no, here's another one. Let's just wait 3 months and see what happens. Versus like if you're really focused on the objective measures of the problem and what things you can't do, then they can engage,
right?
But they don't have time to engage, and I'm really upset.
Yeah,
we'll get those outcomes for you. I guess that long, just like let me get those outcomes for you because I think I love pointing people to you because I know they're going to have a good outcome, and then they're going to say, well, how do you know that? And like, well, I do have faith from all the patients I've sent you, and it'd be really cool to say like, oh, because his outcomes are better. Period. Yeah. I compare him against the normative data, you'll win.
Yeah.
I'm a numbers guy. I'm an ex-engineer, so I can't help
I
think like 93% score, 89, not good enough.
Yeah.
I just thought to my kid the other day, you're like, A-. I don't know. Barely make the grade.
The numbers would be great to see and great to know. It's just, getting to that point where it's all just kind of smoothly writing is the hardest part. Right. But
well,
I would love to know him. Well, I'm always intrigued.
I think it's coming in fast because, like I said, I just had my friend, and he went to the doc and didn't trust it because he knew that 10 millimeters was a data point. He knew that, and the surgeon made the mistake. Now, of course, he's in the so the surgeon could give a rat's ass about his performance with an individual person. But he should. And the point is patients will be more proactive than ever because they will have a data point that will pressure test us all as to how we engage with them. And I think when you, when you're here for the right reasons and you're trying the right thing for people, it all just makes sense. What's the best for the user?
Right.
That's going to be the crazy thing is how handy information is nowadays, right? I mean, like, especially with the new AI systems and everything. Information is not...
It's very accessible.
Yeah, it's no longer the variable.
I know. These new people are going to say, hey, are you going to help me with more linear stability or rotational stability? You're like, what? Why do you care? Because I do. Who's to you to tell me what to care about?
Right.
And that's what they're gonna be in very informed car salesman or a car buyer.
Right.
They're buying a new ACL.
Yeah.
Prove me that you're the one.
Right.
Yeah.
And I think you've done an amazing job whenever you do connect with people. I applaud you for that. But that's going to continue to be the case, that people are going to come more informed.
Yeah, they are.
Yeah.
I think it's good. I don't think there's anything bad in that, right? I mean, it's enjoyable to see some people who are really, they're really bought into their own health. You don't see everyone bought into their own health, right? You don't see actually very many people. So when I have people come in and they're just like firing off questions like, why do you do this? Why do you do it that way? And
those are the best.
It's
patients.
enjoyable, right? Because I'd be like, all right, good. You understand. You have a level of understanding. Let me tell you why.
Yeah. And this is where you really shine, right? It's like, you can answer those questions. This is why I make the decisions I make,
Right, right. And that was one thing, one of my, Bill Montgomery, he was also a Kerlan-Jobe fellow, and he was attending of mine in residency. And one thing I always loved about him is anytime someone asked him a question about how he did something, he had an exact answer. Right? He had reasoning behind it. It wasn't because this is how I was taught.
Yeah.
It was never that.
Yeah, right.
It was, no, I do this because yada, yada, yada.
Yeah.
Same thing like Elatrosh. We're talking about ACLs, right? What I loved about Elatrosh, going into Kerlan-Jobe, 2019, at that time, and still now, everyone's like, oh, biocomposite screws, right? For fixation, right? That's the theory. No more metal. Metal's archaic. Stop using metal. That's how I thought going in too. Going with Neil Elatrosh, and Neil does all metal. Right? It's BTB, and he does all metal as long as the tunnels match up.
Yeah.
And so I started asking him, like, well, why are we doing metal? Why does it seem so old school? For one, you're talking that way to, Elatrosh, who clearly has a good track record, right?
Yeah.
But he makes it very simple. He's like, look, when I have metal, for one, I don't have to worry about a screw breaking, putting it in, right? Because metal's going to cut through bone. That's not a problem. He said, on x-ray, I can see my x-ray. I know where I put it. I can confirm where I put it. There's no hidden, trick going on with the plastic screw that you can't see on an x-ray.
Yeah.
And for everyone else to see too. And then he was like, guess what? If I have to revise it, guess what's going to be easy to get out? A metal screw. Mm-hmm. And not to mention, metal screws don't create osteolysis, right? Mm-hmm. And so you're not going to destroy those tunnels if you have to revise them in the future. Mm-hmm. So I'm like, well, that's pretty sound. I guess I'm using metal from now on.
Yeah,
right?
yeah.
And that's been a trend, right? As it went that way, right?
Yeah.
Where like the biocomposite was like, this is the greatest thing, it'll be great. But then actually people moving back to metal now in that particular example.
Right.
Sure.
And I mean, I love metal. It's my preference. The only like biggest risk of metal is you can cut the graft, right? So it has to be where the bone block is sitting perfectly at the opening of the tunnel, right?
Yeah.
And you can put it in, protect the graft. But
Yeah.
that's the only real risk in my mind. The rest of it, it's a very sound, it's inexpensive, right? It's much less expensive than a biocomposite screw, which is nice also.
Yeah.
When I think about, the healthcare industry and expense out there.
Yeah, there's enough.
Yeah, there's enough expense, right? So, metal is the way to go in my mind.
Yeah. Yeah, it's crazy with with the informed patient. I think it's a great movement. I think it's going to make all of us be sharper. I had a therapist ask me the other day. They were like, "Man, like that patient was tough." They had like a lot of, like, kind of put me on the spot. I was a little surprised. I'm like, "There's more coming."
It's coming. Yeah.
Welcome to the game.
Yeah.
If you want to be at the tip of the spear, if you want to be decisive in this profession and make a difference in people, like you started with, like, you got to be able to make a decision, right? You got to be able to have an opinion. And that's, at the end of the day, that's what you're getting paid for. Is not so much, do you know everyone knows the information. Mm-hmm. The question is your interpretation of the information relative to the person in front of you, how old they are, what sports they do, what activities they do, where they're at in the healing process.
Mm-hmm. Yep.
Now take the information and apply it in that environment, and that's what's still, I think, valuable. That's what the license gives you the right to do,
Right, exactly. And so I think going back to your friend's experience with the Achilles, it's like not being able to counsel and educate and speak to a patient, in a manner that gives them confidence, and you educate them, right? Then you already ruined your relationship with the patient, completely. Right? I mean, there has to be a lot of trust. I mean, they're entrusting you with their knee, with their shoulder, with their elbow. Right? They're entrusting you're going to make them better. They're quite vulnerable, obviously, especially when you get to the time where they're on the table. So there's a lot of trust there, and so the first part of building that trust is the initial interaction, the rapport, the counseling. And just making them feel comfortable, right? And that's critical.
Oh, that's awesome. I love what you do, Sean. I think your approach and your passion for the patient and your skill set with the techniques is spectacular. The outcomes are phenomenal. So
I got a fun question, Sean.
Yeah.
All right.
If you got kicked in the thigh,
No,
you couldn't walk for 3 weeks.
It's a fun one on your end. All right, so good for you, but you look quite young.
Yeah.
Elephant in the room.
Yeah.
You've trained at one of the best spots in the entire world, and then you look quite young.
Yeah.
How do you get over that hurdle? Do some patients like? Do they say like? How many cases have you treated?
All the time.
How many ACLs have you done?
All the time. It's every day. All right. I mean, every clinic day, I'll hear it 5 to 8 times probably. Like, I mean, it's.
Do you have like a quick line on it? Or do you like?
Honestly, I think the main thing I tell them is like, all I can tell you is I've done a lot of these. I feel comfortable with my ability, and I will take good care of you. That's all I can give you, right? Like, and I look young. I get it all the time, but I've done, I don't know, hundreds, thousands of ACLs, hip replacements. Like I have the experience at this point. But
do you say like prior athlete? Hey, I've been very athletic in my life. Right. What else can I say? I stay in shape. Like,
yeah. Well, let's put my Botox. I get it about every 3. No.
I'd say back to them. Do you want me to look old?
Yeah.
Would that make it better?
Yeah.
I think the people like a young doc because you have more modern techniques, right? There's this magical age where you're like, you're a great technician, great skills, you have enough experience to build that, but you're also really modern with your approach,
Right. Yeah. And a lot of people, when it comes up, they say, I don't mean to be offensive. And I hear good things, but
totally.
How many years?
I don't want to be the first one.
Yeah. I don't want to be the first.
Yeah.
So, the going joke should be, this will be my second one. So I'll take care of you.
It's funny. As I get older, I say to people all the time, like, man, this is really helpful today. I said, I got lucky. It's my first time.
Yeah.
And they look at me like,
shoot. Yeah.
It's a different end of the spectrum. No one said that to me anymore. He looks so young. It doesn't happen anymore. It's disappointing.
I'm sorry. It's called over.
Does it still happen to you? People say it to you?
I just had it the other day. I don't know. She's, in her mid 60s. And I said, I have a lot of hope. We're good. She's seen like 5 other PTs and she's just lost all hope. It's been 3 years, yada, yada. And I gave her all this hope. She's like, I just don't trust it. How many of these have you seen? Like, you can't have seen that many cases. Because I said, like, I've seen a lot of you over the years. And I said, well, how old do you think I am? And then she's like, I don't know. I'm like, well. And she said, like, what about maybe like 40? I'm like, okay, add a few years, but then now multiply that like by 300 patients a year for 20 years. And she's like, oh, I guess that's a lot of cases. So, but I haven't had one in a while. But being a surgeon, like I'm a PT, I teach how to squat. Hopefully, I can show people how to squat. You can take a knife into someone's body. So it's I'm sure you kind of fight that battle a little bit harder than I do.
Yeah, I fight. But honestly, I don't. I think the biggest thing is, my focus is on the relationship with them. Most of the time, if they trust me and I garner that relationship, they may make the comment, but they don't care, right? Number one, I guess that's the long and short of it. They ultimately don't really, they don't care. And if they do,
good, period.
Yeah, and if they do, I'm like, there's people I can send you. I have a lot of good friends in Sacramento. And I always encourage them, if you need a second opinion, let me direct you, right? Yeah. Let me tell you who I would have do my ACL, or I'd have do my shoulder. Like, let me send you the people who I really trust, right? And so I think that gives a lot of trust to people too. And this goes to people who are like going to start a practice, right? Yep. You got to have that level of, humbleness, right? You're not all knowing. Yeah. You're never going to be. You got to be able to give patients the opportunity to get second opinions. And I suggest it to them. I can always tell if they're like kind of on the fence. I'm like, look, let me send you to someone. Yeah. Go talk to someone else. Yeah. No skin off my back.
Mm-hmm. But I think in the process, in your evaluation process, or when you're meeting with the patient, looking through all the information you have and going through the subjective and stuff, I think that your knowledge and your ability to walk through, as you mentioned today, like, hey, this is why I would do these things, and this is my thought process here and there. I mean, that's what people are looking for at the end of the day, is that there's critical thinking happening. Right. It's the same thing we talk to our therapists about. It's like, critically think, work through it, work with the patient on it. It doesn't have to be something that's done in a silo where like you just come up with a thought out of thin air, like, oh, this is what we should do. Like, work with them on it. And I think when people see that collaboration and that relationship and that knowledge demonstrated, like, hey, we could go A or B. I would go A because of X, Y, and Z, and the people are like, yeah, sounds good.
Yeah.
But if you want another opinion, get it,
Right, exactly. I mean, I think you're right. I mean, you give them the confidence and that you know what you're talking about. They're not going to care about other things. They may still ask because it's fun, and they always have like a little smirk on their face too. Right? They kind of know. They know.
Yeah.
But it's part of the fun.
Yeah, that's good.
Sean, good to have you, my man.
Hey, thank you guys.
It's great.
Dude,
Always
awesome.
love hanging out with you guys.
Awesome.
It's a pleasure.
Dr. Sean Robinson, Revolution Orthopedics.
Yep. That's
Currently moving to Folsom. Give him a check out. This is the man. Phenomenal surgeon, phenomenal guy, as you guys can tell from being here. So it's great working with you. I love your hat.
Yeah. See, we got the Kime hat, so
Yeah.
as you can tell,
And
we're closely intertwined.
And thanks for the shirt today as well. I
Yeah,
appreciate it.
absolutely.
We'll rock it as well. But all right, thank you guys for listening to KIMEcast. If you guys have any comments, throw them in the comments below. Love to interact with you that way. Appreciate you guys listening. Thank you again, Sean.
Awesome. Thank you guys.
See ya.